right, and go ahead and call it order this regular meeting of the Seneca Healthcare District. Here we have Shelley's here, Sherry's here, Ken's here. Rich, you're online?
Yes.
Thank you. And with that, let's rise to the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Right. That brings us to our item number 2, election of officers. Thank you, Rich, for reminding me that we forgot to do that last meeting. So, I will open up the floor for discussion.
I would like to nominate everybody to stay in the same place that they're in.
You stole my thunder, thank you.
Yeah.
That sounds like a second.
Third, fourth.
Rich, are you in agreement?
Aye.
Okay. Then I guess, so you made a motion?
Yeah.
And Ken
I'll
said,
second.
okay, so Rich just said aye.
Aye.
Sherry,
Aye.
Ken,
Aye.
and I'll vote aye. That was the easiest.
That was simple.
Yeah.
Yes.
Congratulations.
Okay, so that keeps all our state entirely the same. Item number 3, additions and modifications to the meetings. The only correction that I have that I meant to correct on the agenda before went out and I missed it was, the medical staff report was actually not, oh, it does say anywhere on here. The one I was looking at online.
Yeah, I went through it, updated it.
Okay, thank you.
Yeah.
Okay, never mind, then I have no changes to make.
Okay.
Any comments on that? Okay, thank you, Deborah. All right, so then that brings us to item number 4, approval of the agenda. Do I have a motion?
A motion?
Thank you. Do I have a second?
Second.
Thank you. All in favor, Ken?
Aye.
Rich?
Aye.
Gary? Shelley?
Aye.
And I will vote aye. Okay, so that brings us then into our public comment period. One in the room or online wishing to make a public comment? Okay, hearing none, and there was no comments or anything submitted before the meeting, so we will move on to item number 6. Approval of December 16th, 2025 special board meeting minutes. Anyone have a chance to review the corrections, comments?
Move approval.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Ken,
Aye.
Sherry,
Aye.
Shelley,
Aye.
and Rich,
Aye.
and I will vote aye. So now that takes it to item number 7, our staff reports. Sean, you're up first.
Great. Well, since we had a meeting in early January and we're now having another meeting in January, and in between there, I had a vacation to Hawaii. I would like to report that the weather was balmy,
Rubbing in.
a little bit of rain. But I
As
recommend the uku fish. The uku fish is excellent. I don't have much of a report. It's verbal. Like I said, I was gone for a week. Thank you for the board for letting me do that. It was good decompression. Only thing I have to report on the federal level is that everything's been pushed down the road. So extensions on everything from the telemedicine extensions to the dish funding extensions have all been pushed. They've been extended until such time that they can get rid of the shenanigans that's going on right now and get back to work on HR1. Now it just doesn't seem to be a high priority, and we are now facing another potential shutdown. And I did see today that the Senate voted to not fund, I think, or something like that, to not fund Department of Homeland Security. So anyway, so that's where they're all holding. So HR1 is still in absolute 100% limbo, but they did at least grant extensions for the payments, those things. And really, other than that, there's really nothing else to report on a federal or state level from a political perspective or from the future of healthcare perspective. And that's really all I have today. And I think the other reports will cover the operations.
Thank you,
Okay.
Sean.
Thank you for the vacation.
Okay, so it looks like Judy, you're up next.
Okay, my report will also be pretty brief. Just as far as the public health update, we're definitely in flu season. We're seeing a lot of influenza A. CDPH is reporting it's the newly emerged influenza A strain H3N2 subclade K this year. They're still strongly encouraging people to go ahead and take the flu shot, even though it may only be healthy, but it still is effective towards other strains outside of this very virulent one that is affecting people of all ages, including children, resulting in some deaths across the country. We've only had 1 or 2 hospitalizations so far as a result of this. So if you haven't got your flu shot, there's still time to do that. Wash your hands and be careful. Lot going on, as you know, with our new hospital. What Brady and I will be focused on beginning next week will be restarting our transition steering committee. For those of you that were at the USDA meeting yesterday, you already got to hear the spiel on that, and you'll hear from Donna later that we're also we have invited proposals for kind of an overarching transition steering consulting firm, and there will be a recommendation later to you about that. But what I'm talking about is more of our internal TSCs. Brady and I have identified what we feel are the 4 top departments to start on in February, which will be our laboratory, our skilled nursing, dietary, and surgery that we feel have the more complex transitions to overcome in the new hospital because of the change in their workflow, the ginormous space in comparison to what they're working in now, the probability that they will require increased workforce as well, and brand new equipment that they may not be used to using in their current environment. So we're doing a multidisciplinary meeting, so where we can have even like environmental services, how will you fit in or not fit into that? Will surgery be doing their own housekeeping, or will EBS play a role in that, et cetera, et cetera. Dietary is very complex in that not only will they take care of 16 residents, we hope there'll be 26 residents, and also taking care of our inpatients. And then eventually they need to figure out when they're going to open up their Blue Heron Cafe and start serving the public, and what will that workflow look like. Everyone's still really excited, and we'll be reporting back to you on that. Our CNA training program is going well. We finished our 4th week this week. All 6 enrolled students are still showing up for class every day, which is great. Our CNA graduation has been slated for March 31st in this room. No regulatory activity updates. I'm still collecting items for the Seneca Auxiliary wish list. That list needs to be compiled by mid-February, so I put out a reminder to all the managers if they have something that they would like on there. Otherwise, if we come up a little bit short, we have some other ideas of how we may be able to utilize any of the funds that the auxiliary will have to support our new hospital. And I'm sure Brady will give an update on how well things are going with our new podiatrist, and our new physical therapist is doing well in supporting him and supporting the nursing services, because we've had some complex wound care patients, and she well the experience in that realm, and she's been really great in that regard. And so unless you have any questions, that's my report this month.
Thank you. Any questions for Judy?
Thank you.
Thank you.
Good job.
Thank you.
Yeah.
Okay, you have something, Rich? Unless you misheard, okay. Let's move on now for the year report.
Okay, so I do have some updates on this was put in for the clinic. So if you've noticed or not noticed, we have a button out at the clinic, so the automatic doors, we're fine tuning it a little bit. The first position was a little farther, but so far patients, if they see the button now that we have a baller and it kind of stands, are liking the doors. Prior to that movement, we had a lot of complaints that the doors were heavy. Downside of automatic doors is the pull on them are heavier than normal doors. So we're fine tuning that, educating the public on that. As Judy said, the podiatrist, started and, really started, well, a lot of referrals. We've already done, surgical, surgical case, and they have more going, so that seems to be, going well. Chelsea will work her magic as funds are coming to get that one more out in the public of that service that's added. When it comes to the, Judy and I have been working on a lot of moves, so as we're adding services or preparing for what your workflow will look like in the new space, or adding PT in the swing program, we have to move a whole bunch of dominoes, forward to, make it so it operational works. So right now, as an example, if you need an ultrasound, you would be going to the main hospital, you would be registering and you pull back in one of the rooms in the back of the hospital. But as our swing program is up, up and running, we need that acute bed back. So we've had probably like 10 different moves to actually get an ultrasound into their final spot. So there's gonna be a lot of that as we're adding services in the smaller shell. But it really kind of aligns with how their workflow will be in the new hospital. So we're taking that into consideration too. In a couple of the projects in the clinic, we're still adjusting our staffing model. As the winter time, we usually bring in some per diems and train so we can handle the phone volumes and all of that. We haven't got the full, usually by now we have everybody in their position and we're training, but we haven't got a lot of candidates to fill all the spots. So we're adjusting and doing that, so we're ready for the volume and we're ready for the summertime now. I usually say the winter time is light or lighter, but this winter is proving me wrong. The volumes are a little higher than our last winters.
There's less snow.
It's less snow or something, yeah. So there's a good and a bad. So part of it is the phone volume is picking up, so we're seeing how we can adjust the resources and staff so we can handle that uptick in volume. The numbers for the clinic, one of my analytics in the back, last December and this December, or excuse me, January, are probably about the same, if not a little bit more. But year over year, we're pushing probably at least 150 plus over the following year. So we're holding to the budget, if not slightly over, but we'll see. February is always a dip month, so we'll see how that works, and then the months after that. So that's on the clinic. And then in here we have the radiology report, and you'll see finding MRI is on the board. So ultrasound surprisingly is still holding strong. So all of those services, you can see the volumes there, which is within budget and pretty normal. Some of them parallel the providers that when providers take time off or that, so that's pretty good.
Something to point out, if I may, on the MRI is we've only really calculated just a little over 1/4 in volume, so we expect that it's gonna exceed any of the prior years if we can get a full year's worth of volume.
Yeah, we budgeted, I believe,
It's been really
it's gonna Steve, correct me, 150, I think it was, for this, and I think our, which is 12.5 per month. And we've been booking like 17, so I mean, the numbers are higher than at every week. Now, we've traded some days and stuff with the other hospitals to help in there, but It's looking pretty good.
How far are we booking out?
We're about 2 weeks out. So we try to keep
Pretty good.
within that
Yeah.
zone, that's acceptable MRI, I mean, that's good, but acceptable in the MRI space. So anyway, good things that, when it comes to the partnership members, everything's to be, pretty steady. And that, so that's what that, for the sheriffs. And then clinic volumes, all of that seems to be, moving in the right direction for this year. Our zip code analysis, these are our standard reports. When it comes to, two reports as we go through this calendar year, I usually talk about recruitment. Shannon and I, what she, does also, kind of have the whole foundation of recruitment in her report, so we're gonna push that over there. And I will compliment anything that she needs me to say, but she'll be holding that report. And then when it comes to Ethan, as Ethan, took that role, I kind of folded a structure report into mine. But I believe in March, Ethan, we talked about is Ethan will have his own stand-up report, because there'll be more details and then he can own that report for the board. Because that's it for me.
I think that sounds great.
Yeah. And then, we'll pass it off to Ethan, anything,
Several things to note, but I'll make it brief. As I said last month, we have, had our new hire, successfully integrated. We are beginning training. We are expecting that she will be fully integrated and taken on tier 1 support, within 60 days. With more training set up after that, so that is going very well. Last month, we had the report that the butterflies were having issues connecting with the mobile device manager. After reporting that is fully resolved. We were able to take care of that next week. It was on the mobile device manager's part, and they found a certificate that expired on their end. So butterflies back up and active as far as clinic and ER work that way.
What had expired?
There was a certificate that, without getting too far into the weeds, certificate connected the iPads to the device manager, and without it, they couldn't connect or update. Besides that, we are online for our penetration test to give us a better insight into our network before we go into the new build. That is pending for early February due to workload on the team. And other than that, the reported spearfishing attempts are still fully underway. Stand by for those. We aren't expecting those to slow down anytime soon. We do see trends with malware or phishing attempts where for a few months, something is very popular amongst hospitals. Right now it is spearfishing, where those emails or text messages are coming out from quote unquote Cherry or from any of our executive team. And so as that changes and as those trends come, I'll make sure to keep you guys updated. Besides that, big server news is that we are having a CERT refresh. So our testing environment CERT will be having a refresh in these coming weeks. We're expecting a uptick in issues to come with that, but that is fully expected, and we have our resources available for that. Besides that, everything is, oh, pardon me, the last thing is SharePoint. We have been talking about SharePoint for a long time now. That is underway. So we are currently doing a network file structure look. We have sent out instructions to all the managers to take a look at their department drives and start the cleanup process with IT assistance. And we are expecting the network to be ready for migration in mid-February, with the actual migration taking place either late February or early March.
So you're gonna use SharePoint for like PMPs or?
So we are going to use SharePoint for everything everything that's currently in our network as far as file storage, will be transferred up to SharePoint. Our current file storage will be used as temporary archive until we are certain that the SharePoint is doing the articles.
Okay.
So,
One place.
PMPs is for center now. Yeah.
Yes.
Yeah.
and then 2 things to add, so you can give an update on the iPads and for the board.
Yes, so the iPads go in the same vein as our current equipment refreshes. Right now, I'm sure that AI is well known to all of you as far as how much of it like technical interest. Because of that, products technical products, electronics are increasing in price dramatically and losing availability as people scramble to buy them while they're available. Because of that, there has been a shortage of iPads in that model. I'm currently working with Steven to find acceptable models that will still work with what we need within our organization. There's been a slight delay on that, but it should not take more than another week to get them here and start to work on it.
Is there any tariff impact on those? Because they're mostly built overseas, right?
Minimal, but yes, there is some price impact from the tariffs.
And then the second software, this is for it's more for the organization. Ethan's doing some research on a contract collaborator system. So what that is, it's an archive for contracts, all contracts. It's usually it's usually managed by finances under Steve's umbrella, and they'll set criteria and parameters. And then, as an example, if you have a vendor contract and it's coming up in 90 days from now, instead of you having to remember, hey, I gotta talk to that vendor, it's into notice, and organizations can set that up. That way, we're doing it a certain way and it's somewhat working, but when we get over there and all those contracts that will be associated with that model, it's a good time to get that in prior to, so that we know how to work with it. And then,
And it'll prompt a review of our existing contracts, see
Yeah.
what's current, and what's not.
what's current, what's not, yeah. So we'll, as soon as we do some demos, we'll keep the board apprised of that and show, the different ones. And then when we select down, we'll bring, the whole thing to the board, because I think that will be good awareness, just like Judy implemented in MCN for policies. It's similar nature.
You can update changes within the contract within the system.
Yeah, within the system, and then you have a tracking, and then if you ever,
E-signing as well,
what's that?
e-signing as well.
Some of them do have that capability, they could probably tie DocuSign into it, all of that kind of stuff, so it's all how far we wanna go on that spectrum, but, they're very handy for organizations to
Our
have.
current system is fluent.
Yeah,
Just a little bit, Judy.
yeah, Deborah does her best, but she can only have so many
Well-
binders behind her.
And it is, it has cost us where we've missed a date and it was an automatic renewal for a year, even though we're no longer using the process. And I can tell you, those are really legally hard to fight. They're hard to get out of. The term and termination clauses. So the other thing that some of these things can do that I've used others in the past where legal can go in there, and we have templates. We have certain templates like there'll be provider contracts or
Yeah.
equipment contracts. Legal can go in and update the template according to new California law so that we're always using the most recent template. They have access to it, and that's really, really important.
That would be the next question, was whether we have that capability.
Yeah.
And then be able to provide vendors, here's our contract.
Yeah,
instead of,
yeah.
"Okay, we'll take your contract."
A lot of times I've seen mass, well, they'll flag certain things that are outside the parameters of our contract requirements. Automatically in their contract, it goes in there and goes, no, none of these 8 things are not accepted immediately by, you can get pretty sophisticated with these things if you want, so. Yeah,
I do have a question
Yeah.
for you, Ethan.
Absolutely.
So with our internet disruption, the synopsis in here was that we had to do some manual work to get things going for everyone, is that correct?
Yes.
Well, then I guess my question is,
Oh,
do we have a backup to that? Because what if he wasn't available or not available, or,
Certainly. So we are currently working on some procedures within IT as far as server downtime goes, because with server downtime, with the internet cutting out, with we'll have to work remotely, things like that. The long story short is that the licenses to use server downtime expire every 6 months. And so if someone has not gotten onto server downtime within the last 6 months, it doesn't work. And so we're currently working on some workflow to figure out how to send out reminders to folks, things along those lines to make sure that in the case the internet does drop, like how it did, everyone who is, within the patient care facility can still function.
Perfect, I was wondering if it was something to do with staff training to make sure that we
That-
don't have issues.
That's the easy answer because, unfortunately, certain controls the duo rules, so you can't edit that.
Okay, that's fine, I was just wondering how we were gonna approach that, thank you.
I have I'm sorry. I have a related question, I guess. I just noticed here, Brady, that the report, it says you had an electrical outage at approximately an hour and a quarter. And I'm just wondering, hour and a quarter, I thought we had generators that kicked in
We do.
immediately.
It was just a main power outage. Our generators do,
Yeah.
but I can tell you with the current structure of the campus, our generators do not produce enough power for certain things like our CT.
Okay.
And it's not on e-power. We don't have enough capacity. So it does affect our operations. We have to go, it's not a diversion, but we have to know that our CT is not available. And we let everybody know that. So certain things that are not on e-power, it does hinder our operations to a certain degree. In the new facility, just to let you know that there's more e-plugs out there than we probably need. So everything's on emergency power. So
I would just, yeah.
Yeah. it does affect us.
Yeah, the positive about how this building is built, there's more generators, that we have. That building and these outbuildings that most organizations have. So down in the valley, if you're not connected to the main campus and on the generator, you're closing your clinic for the day. So it's positive.
And I have another question.
Yeah, I had a question for Ethan. So the Cerner downtime, I know we have downtime policies. So what is the Cerner downtime that you were talking about?
So
How does that work?
Cerner downtime is a different, web link into Cerner that you can access, makes it so you can access Cerner while you're not physically here. So for any of our providers. who are
Oh, remote.
on-site, they use Cerner.
Remote, got it.
And it's
Okay.
just the authentication method.
Okay, got it. Thank you.
Absolutely.
Then I have a question for you, Brady.
Yep.
So I'm looking at the zip code analysis. And it looks like from last year or from 24 to 25, we didn't really pick up a whole lot of unique patients, but we're having more clinic visits. Do we know if that's because we're educating people that they need for preventive screenings or what the reasoning is for that?
So you,
The numbers are about the same. In other words.
And if you don't have an answer, that's okay. I was just curious about that because I thought, well, if our clinic volume is going up, but we're not seeing that many more unique patients. Where's that coming from and how can we?
well, so this was 24 to 25, so it's.
Like you took us through the secondary service area,
Mhm.
oh,
The
just
grand total.
overall.
The grand total, okay.
Yes, yeah, I guess so, 2556, 2552. So the numbers are pretty much similar as of end of December, a
Mhm.
little bit.
I would question the efficacy of 2024, honestly. The efficacy of 2024 numbers. I mean, we were just learning to get data out of Cerner.
Oh, so you're saying that you don't know.
Yeah, I don't necessarily trust what we got in 2024, because I think it was shoestring. a little bit.
Well, and our clinic volume for, well, our last fiscal year volume, not the fiscal year we're in, we ended up at 10,364. This year, we're trending at 10,800 over.
Mhm.
So we're definitely picking up. Now, we started this fiscal year, like our numbers were similar, but we keep gaining ground as we go.
So, and these are patients, not visits.
Right, right.
Yeah,
Oh, I
right.
understand that.
Okay.
Yeah,
Yeah, I'm just, if it's, if these are correct, then, if our numbers in the clinic are increasing, then these patients are coming in.
multiple times.
More,
Yeah,
right.
that could be it, yeah.
Yeah.
That they're using, and in 24, Westwood was turned on, turned off, or turned off, turned on. So it could be that, we're actually getting established patients from Westwood and there's seeing
It
as
does look
more.
like that part
Yeah.
did take up, yeah.
But that is a good question. I'll dig in it with Candace to see, but, that would make sense if they group with one versus multiple visits.
And I think this correlates and reflects a little bit on our ER volume, which has gone, which isn't what it was.
Sure, yeah,
You know, which is, it's sort of a push me, pull you.
that's a good
People are
point.
seeking general practice care, they're being followed, so they don't have acute onsets. You know, it's one or the other, so using the walk-in, or they're being managed, so they're not showing up in the emergency room. Which is great, that's good for health, all right? But our volumes in the ER have definitely taken a downturn in
Yeah.
2025. We're hoping that obviously summer is always our high ER volume anyways.
Well, and maybe we can come up with a clinic data point that shows the average patient per clinic visit. So like when you're 65 or older, the stats are, you see your provider receive healthcare services about 6 times a year. When you're under 25, it's never, you know, when you're invincible. And, you know, so there's all these different stats. So if we could find the national stat and then compare ours to it, then that would kind of, go along with our demographics too. You could kind of look at it that way.
And it might give us a place where we wanna focus our marketing too.
Yeah.
What about that report that you and Candace pulled in one of your first reports, and basically it had type of visit? Because it said, oh, this is a new established patient, this is.
Yeah,
right.
Returning for a prescription or whatever. Could we compare those year over year?
Yeah, and we'll bring our full portfolio of reports, you know, quarterly, so we'll look at it with those lens and see if we can get a ratio, like so many visits, what's the average visit per patient, so we can watch that. You know, cause if we do a good job, you think that ratio would be higher, because more people would constantly come in versus one visit and they're done. Yeah,
Yeah, because there's different populations we're trying to hit in different ways, yeah.
yeah,
Not hard though with a tourist population.
yeah,
The nice thing is with Cerner is you can parse this out
yeah.
much different than we used to be able to. The data's there. It's a matter of, what do you want to look at? Because it's in there, we just have to slice and dice it.
Thank you. Anything else for Brady? Anything else to add, Brady?
No, thank you.
Thank you.
Yeah.
Okay, Shayna, you're up.
Okay. So we have been recruiting for nurse practitioners. We had one come on site in the month of January. And since then, I'm reporting that she has verbally accepted our offer. So that's great news. We also have an interview on Friday or tomorrow with another one. So,
Where does she hail from?
with one.
The nurse practitioner.
The one
That
that's.
verbally accepted.
She's with work at UC Davis, exactly, yeah. Yeah, great. Our CPA renewal, the 9th, okay. Things are wrapping up. We have a few more proposals to kind of fine tune. But we did provide our final and best offer as far as compensation goes. So that's moving forward. For physician recruitment, some updates. I'm taking over for Brady. Dr. Goodall is starting with us late March. He does have some dates put on the schedule. So he's gonna be picking up some ER shifts and some walking clinic shifts. Then we did have a family practice physician that we all interviewed over the phone, that we have not, decided to not move forward with him. We do have another physician that's interested in ER and walk-in. He is coming for an on-site visit in late February. We have had a little traction more than last month. The HRSA job posting, we have an interested candidate. Did you reach out or did they get in hold of you?
No, I reached out with a message.
So that, at least someone was interested. Then I have someone that I've been emailing from Dog Cafe. He's actually from Jackson, California, so maybe that will work out. Then as far as HR, January was busy. We onboarded 12 new hires and we have 5 conditional offers out there, so. That's all I got.
Awesome, thank you.
And I love your piece in the newsletter.
Yeah. Good.
Any questions for Shannon? No, thank you.
Thank you.
Okay, that moves us on to Chelsea. Thank you, marketing is good. So, lots going on right now. We have. Okay, I can see them. So we have, we're still pushing out MRI services, so what we have coming in right now for MRI are more patient, like patient-facing stuff going on, as well as stuff for other clinics and areas around us. So especially like, so we have the doctor's offices and places in Susanville that, you know, it's an option to send people here, whether they will or not, we don't know, but we want people to have that option. We also want the patients to know that we have that service available up and going weekly, so that they can say, hey, you guys can't get me in here, can you get me in over here? So we have, rat cards coming in for that, and then we also have more, marketing, like targeted ads going out for the MRI services, so that's continued, that we have a plan for the next 6 months that will continue. We'll have different things going out to the community for all of that. We've also started to launch the podiatry marketing plan, so for that, we have a whole combination of things that are going on, from his, press release that went out last week to, we have a video that we're going to be doing with him on the 11th, so that video will be introducing what podiatry is, why he's doing podiatry, and then touching on, you know, what he'll offer here at Seneca. So that will go out to the public as well. We also have a live radio, live at 7 scheduled for him in the upcoming weeks. And then we have all of the print material coming in for him. And so we'll continue pushing along and marketing that. He's very eager to build up clientele and, to service the community. So he's been really fun to work with on all of that, because he's really involved in getting all of this stuff out there. So that's great. We also have website updates going on, adding podiatry pages and all of that we're working with him on to make sure we have all the services correct for what he wants. We have updates for the community. So one of the major updates that we sent out was Sean's retirement notice. We got great feedback, great responses from that. We noted Brady in there.
They all want me to retire.
No, they're not congratulating. Not in that
They're
way.
like,
People,
yes.
and people liked that we had, here's the plan going forward. They really liked that, because it made them feel, you know, it makes people feel more reassured. I got less questions about Sean and more questions about Brady from it, and it was just, who is this person?
Yeah.
So we're also working on a marketing plan with Brady, and a kind of like a schedule with him to get him introduced to these different groups and through the community over this next year, so people learn who he is a little bit more. Brady went to the Elks Craft Feed, he's going to bingo, he's going to. He's got, his schedule is getting booked up with all these things out there, so people get comfortable with, oh yeah, Brady, I know who that is, I met him. We'll be at the band shell twice this year, the weekend after the 4th of July, and then again on the weekend. So those are the two that we're sponsoring, and we'll make sure we get everybody up, introduce everybody, any changes. We always welcome anybody that wants to join us for those. So other than that, Lori Cooler. So that's the next thing that's gonna go out. We're prepping the patient letters. Those have to go out. The 9th, I have to have them in the mail, because for the state, they have to be out 30 days in advance. So, we're prepping those, but we're hoping that we have a signed person that officially has signed by that time, so I can in the patient letter say, yes, here's who we have brought on to transition this practice to, and give them, here's this option, but as always, you guys are welcome to pick any of our providers that are accepting patients. So that's how the letter is kind of laid out right now, and so I'm just holding until we have potentially a signed contract, and I can say, okay, we're gonna put this out there. And then after we release the letter, we will then release a PR, but we want to send out that letter first and then a PR. We did send out talking points to the staff, just so staff knows, because it's a small community and people are already asking everywhere I go, they're saying, what's going on? You know, we hear about this. Lori's very open. She wants to tell the world she is moving closer to her grandbabies. She gave me a picture for the press release that has her holding her grandbaby. So she's very open. She's been great to work with it. So I think it's it's nice to be able to have a community, this is what's going on.
Chelsea, we are getting, she is making, when she speaks to her patients,
Yes,
she's notifying them the timing on the press release and stuff, so it's something I have to really pay attention to.
yes, she's letting her patients know, we've already, been talking to patients.
Or
So
reach
to
out.
get to that point, though, I understand holding on the letter. You might wanna consider doing a press release sooner, just not meaning necessarily. Right.
The new
Because,
person, yeah.
right, like you've started to hear from people wondering about it. Right. And they're confused about what's happening. Right, so we can release the press, so we can tweak the press release slightly and just kind of say we are currently working on a transition plan. I think that'd be a good idea. Then we can follow up, yeah, we can do that, because it's already ready to go, so we can do that tomorrow, it's not a big deal. And I have a question for you before, when we're talking about press releases, have we posted, like, learning podiatry and things like that, do we post those at the post office? So we do, we post them at the post office they will take things down that are not like an event coming up or things like that, so those things don't stay up very long there, it's usually a day or two before they get taken down. Why I don't see them. Yes, we do post them at the post office, usually take them all around like the local coffee shops and places like that, just for those people that don't get online and read them online. We share them at the radio station and they usually read them in the mornings for us, so the next morning after we release them and then put the snooze and all of that. So, yeah, and if there's ever a place that you're like, oh, it'd be nice to post them here, why do you post in those places? It's gonna be, just let us know. Other than that, just lots of things continuing. What's going on? Any questions? Any questions for Chelsea? No. Thank you, Chelsea. Do you want to stay up for your foundation report? Which is our name? Switch your hats. Next one. Okay, so foundation stuff going great. We are, right in the middle of all our golf tournament prep, so we're prepping everything for golf tournament. We're already getting sponsors in, which is awesome. Working on all of that. We're also working on our impact report for donors, and the impact report is where we gather all the data from like, here's what we did last year, here's what we brought in, and we share it with donors and the community. So we are working on that. We're hoping to have that done in February and send it out to people as well as print it and have it available in person. So we are working on all of that. We are also working on all the different signage and recognition that we have to do for those people that did, but like whether it was they bought a beam, so they've got to be on a map, or the people that have sponsored a room or sponsored a nurse's station. So we're working on all that, and we're working with getting in contact with all those donors to make sure that they are recognized the way they want to. We're also looking at the Allen Foundation, when they raised funds before the foundation was up and going. They promised bricks to everyone. So I'm working on obtaining a list of those people that they told we're gonna get bricks. We're gonna discuss with the team how to incorporate that into.
No bricks in the design.
So anyone that donated over $1,000, they told could have a brick during one of their events. And it was an event that they fundraised quite a bit of money at that event. I don't have the exact number, but, so I'm working on getting that list, and then we're gonna figure out how to make sure we still recognize those donors, because we want to make sure that, yes, no one's forgotten, because I don't want someone to come back to us years later and say, we got a brick. Yeah.
Where is it?
Yes, so that is also another thing.
Here it is.
So we are still getting people that are, buying beams. The Elks Lodge did buy a beam. They're gonna be here next week to sign, but
Better hurry.
where's
it gonna be?
probably in skilled nursing. So we
Okay.
still have exposed columns in the skilled nursing. And then Jimmy said, if people wanna reach around and sign, we can still sign for another 2 months. So we'll see. We're playing it by ear. We don't wanna extend it too far, and then, yeah, so yeah, we're brainstorming on different ideas for future fundraisers. A lot of people want to get into a tour of the build, so we're trying to come up with maybe something. We're thinking in the fall to like a walkthrough with like maybe appetizers in line. Something when we're a little closer, things are a little more safe to get larger groups in.
Well, what if we schedule certain time slots
or smaller groups.
And we,
More frequency.
anytime someone
Right.
calls and says, we wanna go out and get a tour,
We pretty much
we
accommodate.
do.
Right, I was just
Yeah.
thinking it might make it easier for you if there was, if you had a set
Yeah.
time, that this is what it was gonna be, and then people could.
I don't think
sign
we've
up
ever
for
said
it.
no. It is, I can tell you that it's getting harder to tour now,
Right.
Yeah,
because they're starting to put in the stuff in the ceilings and in the walls, and there's just
So much
stuff
going on.
everywhere.
all the crews going everywhere.
Yeah, it's,
We're supposed to, unless we like, you know, talk to the contractors and work some stuff out, we're not supposed to take more than 10 on at a time for a tour. So like
you
with
see the
the,
look on their face when we did the USDA.
yeah, so like with the Elks, if they bring more than 10 members, we're gonna have to take them in groups and kind of break them up, or, you know, it's too many people like all together in one hallway. Now, Sean could be over here with 10 and Judy could be over here with 10.
Two different.
Brady could be over there with 10, like that's a little bit different, but if you have 30 people all trying to cram down the hallways,
Yeah.
it interrupts work a little bit more than we want to. Otherwise, we could plan for maybe like a Saturday when it's quiet out there.
Yeah,
So,
no
That's a good
problem.
idea.
I can tell you,
yeah.
just from the tours that we are doing, it gives our community an entirely different perspective than just that wall that they see from Main Street.
Yeah.
When they go in, it's like, oh, okay, gee, didn't know this was back here, didn't. So it's fun to watch the look on people's faces. We want to continue that, but we've got to be really aware. of
I'm
the-
glad you're
the
trying to
number.
do some, get people to come through earlier as opposed to later, because I think they go back out in the community and that generates excitement. They talk about what they've seen and what's going on.
Yeah,
So Chelsea, on that note, you know, we made the leap from open toe shoes, sandals, but Rod is really wanting hard soled shoes.
Yep.
He doesn't even want tennis shoes or anything
Yeah.
anymore. There's too many hazards,
between
so
nails and
we
stuff.
need to just remind people that they, not only do they have to be closed toed, but they gotta be hard soles. There's hazards.
Okay.
Or like hiking boots.
Yeah.
Yeah, like hiking boots or work boots. I mean, most boots are work boots, or, yeah. Gonna be
So-
fine.
You might have a
Yeah, we
drop
will
off page,
update our-
patients if you do that.
Right, yeah, that would be great. We'll update stuff and we'll make sure too, as on the time being, that we're saying hard soled shoes, not just closed toed, so.
You might say boots.
Yeah, just
Yeah,
think,
well, it's do say boots right now, just because that's it's winter anyways, it's muddy. Every once in a while, you'd be surprised, we tell people show up with boots, pants, and they show up with shorts and flip flops, and we're like, okay.
You're so nice.
But not.
Yeah, there's been a couple that we had to scrounge up pants and figure things out for it, so. Yeah.
but we definitely want to continue these. They're very positive.
Yeah. So, any questions?
Any other questions for Chelsea?
Okay.
Thank you, Chelsea.
Thank you.
Okay, so then that brings us to our compliance report. Is Charlene on?
Alright.
Oh, yeah.
All right, you can come in.
Okay, so my report is short, as far as OIG and sound exclusions, we are auditing those, human resources, medical staff, and now registration, we're actually auditing all of our outside external providers, for those that are coming through, now that our registration staff are more, open to growth and open to learning new things. We have more the ability to spread the wealth of the work that we have in HIM and registration. And so now we've also been doing the OIG sound solutions for all external providers. Privacy and compliance education, the providers were given training on the 13th of this month. And our rate is still at 86%. And so I need to look and see what's outstanding. Majority of the ones that are outstanding, it's the staff haven't been in, and so I will follow up with each manager and to get a plan to have them train, yeah, we have several people on there that, like, they worked for us last year, they're still on our books, and so, but they haven't come in. So that's why our rate just continues to be,
Like per diem?
yeah, per diem,
Diems? Okay.
yes.
So for those, I mean, if they come back to us, then they'll have to do their training obviously
Yes.
before they start, but do they need to feed into this percentage if they're per diem?
I could calculate it and identify those that are per diem and show the numbers.
Yeah, cause like I'm thinking, yeah, cause per diems, if they're, you know,
Right.
as soon as they come back, they're gonna have to do their training. So, I don't know, yeah, I think that.
If they're not scheduled, they're not scheduled, yeah.
Yeah. Okay, and the next item is new confidentiality requirements. It's a requirement now for consumers to be able to request request restriction of their records online or via online, and so that has been put into our patient portal, and I've circled it in orange there at the bottom. So if a patient wants to restrict portions of their record, they can just click on that icon at the bottom and it'll take them to a form. We haven't had any since we've turned that on, but however, we've gotten messages as to, hey, I'm requesting copies of my records. And so patients are using that to communicate to HIM.
Now, if they request a restriction, that restriction able to see their own portal?
No, basically, if they're requesting restrictions, so for example, if they were to say, you know what, Brady works there at the hospital, I don't ever want him to access, those are sample restrictions. Those are, and also other types of restrictions could be their spouse or
It can
another
also-
provider.
It can also break it down to any behavioral health records are not to be released without my permission.
Yeah.
So they can,
But how are we tracking that? I mean, so if those records were requested, how do we know not to do whatever X, Y, or Z is that the patient asks?
So there's ability in Cerner now to set confidentiality requirements on there. If someone's requesting a restriction, we review it and determine, can we comply? Because there's times that we can't comply with their requests. So it may be like, Charlene works at your hospital. I don't want her ever looking at my records. What are the chances of me not looking at someone's records because I am the HIM director? Those are the kinds of things that we have to keep in mind as to, are the restrictions valid? I mean, can we comply with them or not? But as far as that, Cerner is still working on making a workflow so that we can comply with these restrictions, because you're right, if I have an end user who's releasing records and they don't see that request for restriction, then it's a problem.
so what we're saying is that Cerner's gonna notify that there's restrictions to these, like if you get into their Cerner record. Well, it'll be a notification saying.
Not, right now, we don't have a notification, but we can certainly set that alert to notify.
So it's not automated, so when somebody says there's restrictions, how do we make sure that people going into the electronic health record, when they get a records request?
Yeah, because so even if we have the alert in PowerChart, unfortunately, we're releasing in a totally separate system, and that system does not have any alerts. So Cerner still has a lot of work to do to make sure that we can comply with these restrictions and not accidentally.
Okay, so how does staff, when they get a records request, how does staff look for a restriction notice? Where do they have to look?
As far as,
And do
so
we,
right now, if they're looking in the chart, you can see that like a lock But however, if they're just releasing from the release of information application, if we have put locks on certain types of documents, that'll restrict it from releasing. However, if we haven't put the locks in, then it could accidentally be released. So if there's for insurances, it's still a work in progress and Cerner is still working.
Yeah, but we can't say Cerner's gonna do it. We have to do something now so that we're in compliance before Cerner gets whatever systematic piece in place.
Well, and bigger than, if we're offering this in the portal and they are able to select and restrict,
No, we don't do anything.
we have to have a process by we guarantee them or take that off, you know, like.
Cause then we have liability if
Yes.
they think they've
Yeah.
restricted
Yeah.
and we're just,
Yeah.
No, and that's where patients have the right to request for restrictions. However, we can decline the request because we don't have certain
And let's
processes.
just say it's not something that would be a declination. It's something that would be normal, like I don't want Uncle Bob. Whatever, I mean, that's ridiculous, cause Uncle Bob doesn't have a PTO,
Or
but
your ex.
I wanna restrict,
That's fair.
okay? And then I get a records request into the office. What processes does staff take to ensure that we have approval to release that, or it's not restricted?
Right.
Once again, if we have a process in place, awesome, we can keep that up on the portal.
Yeah.
But if we
Yeah.
don't have one that's foolproof, we're allowing people to select restrictions. But if we don't have a process to ensure those restrictions.
Yeah, and at that point, we can decline and say, I'm sorry, at this point, we don't have, like, I'm not gonna approve the restriction unless I am confident that we can make that restriction.
Okay.
We can comply with the request.
So,
But it sounds like we can't.
so, sure.
What do you mean?
So,
There's times that we can,
Let's
it
take this
depends on what's being requested
so
for restriction.
you have restrictions right now on certain patients.
Yes,
And so what does your group do when you're releasing
So-
to double check?
so an example is the restrictions that I have right now, it's usually from another employee
Yeah,
accessing their records.
yeah,
So pretty much if we've talked to the employee and said, hey, you can never go into this patient's chart, even if they come through as a patient, you have to defer care to someone else. So it's
So-
that type of restriction.
yeah, so when it comes to internal from employee to employee, we have processes in place. So that it restricts, you know, if they have a relationship or whatever, so it restricts them and we have audit capabilities in Cerner that you can see your mouse waving over the name. I mean, it's so detailed
Yeah.
in there. So we have those processes.
Yeah.
But when it comes to.
So the types of requests that we receive, it's usually from the insurance because they received a bill. And so they want copies of the records. And so if a person asks for a restriction from their insurance, they would have had to pay upfront. It would be self-pay, and we could identify that record was self-pay.
So what we'll do is we'll take this
Yeah.
offline, we'll build an algorithm, so it's better visually processed depending on who it is, employee to
Yeah,
employee.
every situation is so unique that until we can see, like historically, some of the restrictions that we've had, we've just put it at the medical record level to indicate that there is a restriction. So when they look at the release of information record, there is a restriction document, and then staff are supposed to look at that and see what is being restricted or what has been requested.
Have we had these CDPH audits because of something like this before?
No,
Okay.
I mean, like I said, ever since I've been here, I've only had one restriction.
With this, with the law, there must be specific things that people are allowed to request to be restricted, right?
Or is it?
They can request, it's whether it's up to us whether or not we allow it. So right now, they can request to have, hey, I don't want this information going out. But once they request that, the provider can put a lock on it. And when we release records, the only way that's gonna be released is by choosing confidential records as well.
Okay, and then does this only come into play with your group releasing records, or does this apply? You know, if, I know a provider's office.
No one else is supposed to be.
Yeah.
No one else is. supposed
Records
to-
releases do not come from the individual offices, they go through.
Yes, yeah, they all should be requesting records for
I
us.
wanna make sure.
Yeah,
Thank you.
Yeah.
Okay,
okay. Anything else?
No.
So another thing which is not on here is that we are doing inventory of the chart room, because I've heard that, that they want it cleaned out. So just to let you guys know, the issue that I am facing is that we have captured the inventory, we're running reports from Evident and Cerner to determine the last visit. However, one thing to keep in mind when I came here, the records were hybrid, meaning some were available on the physical chart and some were available in the EHR. So really, it was in probably 2022 that I would have to say, I would feel more confident saying, okay, that, all that stuff in 2022 and Evident, it was all electronic, anything from 2021 and past, those could be in the physical chart or the electronic record. So what we've done is we actually went through and captured every single chart that is in there. We're running reports for both systems and we're trying to see how many charts we can actually eliminate. The normal is about 70 charts per 2 years. I mean, not 70 charts, 70 boxes per 2 years. And let me see here. So right now, there are about 14,000. And then linear feet is, about 1,400 linear feet of records.
Job security.
So you're doing this analysis, so when I came, there were a couple of providers that were doing the hybrid.
Yes,
Even though we had an electronic health record, I get that. Can you kind of earmark the 2 providers that I know that were doing hybrid? Everyone else seemed to be doing Evident just fine, the exception of 2. Can we somehow earmark when you go through there and go, okay, how many of these are these 2 providers charts?
I can ask, IT
Just
to
to
write a
narrow that
report
down.
which ones belong to those providers.
Yeah,
Um,
one of them was a high production provider, but wasn't taking on any new patients. And the other one is a person that's only here every week or every 2
Yeah.
weeks, so we might be able to narrow the scope for you to just, so you don't have to go through everything.
and the other thing was that too, is that they were creating brand new charts. When I first, I said, we're not ordering brand new charts, and they kept ordering until we got approval from, you know, the powers that be to that we can stop ordering
Yeah.
the folder.
There's some nuance to this. Thank you for taking this on. This is a huge project,
And there's,
huge project.
yeah, and, so Charlene and Kristen and Jana all have stuff up there that we're starting spring cleaning early, so we have additional space, may it be for storage, once the construction goes, you know, we have wiggle room to start working on.
Yeah.
Cause it will take a while.
And keep in mind that there's a lot of the charts that you can destroy with Iron Mountain, but there are also other ways to store off-site.
Yeah.
Yeah, and
That
so.
way just gets it out of all. Yeah.
That's what I'm doing as well, is I've reached out to multiple vendors. Asking for quotes for either taking our charts, scanning our charts. Other options as to what can save us money based on our situation.
Again, Charlene, thank you. This is a huge undertaking. But it's gonna look so pretty when it's empty.
Reusable space.
Reusable space like skills lab and teaching and, yeah, okay,
That's it for me.
thank you.
Thank you.
So that brings us to Steve for our December 2025 financial report.
I'm gonna jump into association here.
Okay.
Steve is setting up.
Where do you wanna be, Steve?
I'll go in the end here. And I'll give a quick glance.
Sure.
So Grace, our ND, I was signed off her.
She accepted the offer. There you go.
That's great.
Hot off the press and back on the press. Nice. There you go. There's your press release.
That's wonderful.
Oh, okay. So, to show that I'm not Mr. Glass half full by choice. I'm going to say that this month's financial report is a good one. So, and there's some things that are embedded within the basic report documents, and there's some things that are going on otherwise that I'll share with you all that enhance the overall report and our finances as a whole. So for the month of December, at a high level, we operated right at our, as you can see, our net patient revenue was $13,152 above the budgeted amount. So that's always good. And even you don't have to scroll down, I'll just talk about and the expenses were in line, they continue to be in line. Everyone's done a really great job of managing expenses to our budget. So that's a significant thing. What it led to was that we had income loss from operations very near budget. And then when we slide down into the non-operating revenue, we had some positive variance in both the supplemental payments for rate range that we've recorded and our interest income. So overall, we had a net income of $6.8 million versus a budget of $6.758 million. Now, I know we have a gentleman here in the meeting, we don't make $6 million every month, sir, so. Our financial statements are somewhat unique in the way that our finances work. And so for the month of December, I recorded, now you can go down Ethan to the non-operating section. So what we've done, or what finance has done, is we recorded the full amount that we're anticipating to receive for the supplemental payment related to the calendar year 24 rate range program. And that's the $7.2 million, 7.223. We budgeted just over $7.2 million we have a positive variance at this point. There's a possibility that this number could change. The two things that we do know is that as part of the things we're experiencing with getting our long-term care payments to settle through partnership stepped up and gave us a $675,000 advance on our rate range supplemental payment, and we received that in December of 25. And we had two pieces to our rate range. One was the partnership, which is the bulk of it. It's almost $7 million. But then Kaiser came forward and did what we think will be a one-time rate range payment. And we received that payment of $440,000 in January. So we recorded the full amount of rate range. One of the reasons that we do it this way is that December is is one of our measurement years for debt service coverage, and so since we know that this number's almost a certainty to be received, we feel comfortable reporting it as a receivable. We have not yet received the balance of the partnership funds as of today. We should receive it any day, whether it's tomorrow or next week, have those funds in the bank. So again, this all flows down to a slightly positive to budget net income of, again, the $6.8 million versus 6.76. Ethan, if you can buzz up real fast to the top, take just a brief look.
So Steve, the partnership monies you're talking about, is that part of the 675,000?
Yes, that's
Yeah,
what they.
we haven't received it.
We have not received the balance of it. They have actually till the middle of February by
Okay,
statute or agreement that they'll get it to us, but I'm almost certain that again, that it'll either hit tomorrow or next week. So very similar operations here where the inpatient revenue was a little bit negative to budget. The good news for the month of December was that the shortfall in swing, which we've clearly addressed with bringing our new physical therapist on. If you have a chance to meet her, please do it, but she's enthusiastic about, she really likes rural medicine and she likes, I guess how the critical access hospitals support communities, and so she's really engaged. It's very difficult for us to find someone that can adapt to our area, what we do and everything, which it appears to be fairly easy for her coming from Montana, which is Montana is about as rural as it gets. So we did offset a little bit of that swing bed variance with med surge acute inpatient days and revenue. The nursing home continues to be strong. And then our outpatient revenue was positive. It was somewhat due December. We had a continuation of the flu and some COVID. We look at the net patient revenue.
is that why the acute bed days are up?
There were 9 days, so it wasn't, it wasn't a big run, so.
Yeah,
I didn't look at any diagnosis, but almost certainly somebody had flu or other symptoms that meant they.
and I have one more question, Steve, I'm sorry to interrupt you.
Anytime.
Yeah, so Judy, we're talking about how the new physical therapist was helping us with some complex wounds. Would we have had to transfer those patients out? Had we not had her services or her skill set available?
Potentially, our nursing staff is getting more and more comfortable with the management of complex wounds, and wound care. She has some different tricks up her sleeve that she was able to share. She actually came in on the weekend, she's slated to work Monday through Friday, but she's like, call me. And so when the patient came in over the weekend, she came right in, she had already connected with our weekend house supervisor. They said, patients here, she came in and they did it as a team approach. So it's really.
That's great.
Yeah, it's just a,
great.
Wonderful. Cherry on the top. So we weren't looking for that, but we got it anyway. And it's really going to enhance the care and some of the outpatient treatments that, we do on the acute care unit. They're outpatients, but we're seeing them in one of our beds. And now we've got this extra resource to increase everyone's confidence in what we can actually manage here.
That's great.
That's really
Great.
She's fun to work with.
Great
Yeah,
find.
yeah. If you haven't
Yeah.
met her, you really should, because she's quite pleasant.
Awesome.
Yeah.
Thank you.
So we look at net patient revenue as a percent of gross, we're slightly below the target of 72.5. The main reason, probably a little bit on the AR reserve, but the main reason is that when we hit our target on inpatient from a gross basis, we get a higher reimbursement percentage, both from what we get on an outpatient basis, mainly because it swing certainly is almost entirely Medicare, and the majority of our acute inpatient is Medicare as well, pays higher than the outpatient services, and gonna say something there, what I was gonna say, in our budget. So we expect to start hitting that as we start to see swing patients. Ethan, real quick, can you go back to page 1, kind of at the bottom there? Yeah, just right there. That's good. So the days left on hand stayed relatively flat from month to month. The big driver on this was that we received that $675,000 advance payment, which offset the loss for the month, the cash loss, if you will, because the supplemental payments was setting up the receivable for January and February, hopefully all just January. And then the accounts receivable, we saw this increase. We had another month of in December, that is, no collections from partnership for the long-term care. The long-term care read about $300,000 on a partnership. So, and then we did see a little bit of growth on the hospital as well. So we'll talk about that a little more in revenue cycle. One final comment about the financial report, or this report for December, is in looking at January. I didn't break it down by statistics or anything, but the revenue that we're seeing through the first of this week is very similar to December. So it should look, our January financials should look very much like this. So questions, comments, anything?
Questions for Steve? No? Thank you,
Good job,
Steve.
Steve.
Hearing for this, I will accept a motion to accept the December financial report.
I'll make the motion.
Thank you. Have a second? Thank you. All in favor, Rich?
Aye.
Ann?
Aye.
Sherry?
Aye.
Shelley?
Aye.
And I will vote. That brings us to item number 2, updated commercial report as of January 26th.
Ethan, can you? Thank you. So I think the big thing to point out here is if we look at the month of January, which is what we're in right now, look at the activity there, you can see a couple significant events there. And the first one, $1 million, is our settlement with partnership on, they paid us for all of our open claims through the month of November 2025. There might be 1 or 2 that we're still struggling with, but for the most part, that was it. We received a payment of $1.2 million. The next, and by the way, so I don't know how we brought this up when we first started working in partnership, that we were still getting paper checks, and I don't know, kind of went nowhere. And with this last go around where we had the issue with the mailing address and everything, we finally connected with the right group about setting up electronic payments to us. I don't know if they call them ACH or EFTs if they're incoming. And we did it like in a day, same day. I don't know, so now we're receiving 100% of our payments from 100% of our claim payments from partnership electronically. So good for that. The 2 lines below the $1 million payment from partnership is the rate range payment with Kaiser, the $440,000 that is in the bank. As we move over to the right, you can see that next to that 440 is the balance of the rate range supplemental payments that gets us to the $7.2 million. We should typically receive the first installment of our property taxes from Loomis County in January. We haven't received it yet, it could come in tomorrow, whatever, but we kicked it out to February. If we don't receive it tomorrow, we should receive it early in February, so that's a good cash flow. But I think what the thing that I want to, I don't know, point out is the right way to say it, but to share is all of that, along with getting the line of credit in place, which we did not have to use. The only thing we used the line of credit for was to pay the attorneys and to pay the commitment fee, 0.25% to Western Alliance Bank, for a total of $35,000, and then we just immediately repaid it. So we have no balance on the line of credit, nor did we need to draw on it for operations. And as we were talking with the bank and others, we just said, I think that nothing speaks louder that there is at least some improvement in our financial position, that last year we really needed that. We did 2 draws. We drew 1.2 million of the 1.5. And this year we've been able to make it through, even with that kooky thing going on with long-term care, that we made it through without having to do a loan draw. So I think that's a great sign. But because of all the things that are happening, where we're at right now on our cash reserves is, if you look at the month of February, later this month, we'll be making 2 intergovernmental transfers, for one for the QIP and the other for the district hospital directed payment DHDP program. So those two together, $567,000. And then in April, we'll receive the supplement, April or so, 60 to 90 days. We'll receive back the supplemental payment part of it. They're reflected right now in April. And what you don't see on this, this presentation, because boy, it really be scrunched down, is that if we go out to August, we have another round of intergovernmental transfers for the DHDP, and it's going to be a bigger one because it's a calendar year 25, which we significantly increase the total pool of funds. And so we'll be making about a $1 million, $900,000 IGT. Right now we have the 2 here in February and the 1 in August fully funded, sitting in our LAIF account. So what that means is that, the 6 million is going to come in here in the next couple weeks or so. So we're able to meet all of our ongoing operational needs, and you can see how the days cash on hand grow until we start making the intergovernmental transfers in the fall. So what we're doing right now to meet this target of AR days, which is very positive, we're even going out to, when we go out to December, it would be our first month since we started the hospital project that we will be above, we're projecting to be above 60 days cash on hand, which is our covenant in our interim financing with Western Alliance Bank. So what we're now doing is we're managing this top line operating income loss. We're managing to that, and any improvement that we get or we achieve on those numbers there, goes straight in our bank account, theoretically, oversimplifying it. And so now our focus can be on operations. We don't have to worry about, we have sufficient cash flow to get us through, with one exception. What we don't have in this projection yet is any capital expenditures outside of the new hospital building. And we are looking at a few things for possible capital expenditures. Fortunately, we've been able, Judy and Brady have been able, and Donna have been able to pull in current equipment needs at the hospital. I can't remember what we call it, like future. Yeah, future purchase or future thing, where the USDA is allowing us to pay for equipment today. Sounds like going to be in the hamburger. Equipment today for through the project for the items that we'll take to the new hospital, like the surgery equipment and I believe the imaging equipment, the ultrasound equipment and things like that. So the good news is that we're really covering our bases with any equipment demands of the hospital that would have to come out of our operating cash flow. And between that and the great support we get from the auxiliary on their wish list thing, that we're pretty well covered. If something comes up significant, I'd like to think we're gonna be able to take it over to the new project, but it all comes down to can we cover it in the budget of the project and all, and right now that's all looking good. So it's more like if we're looking to do anything here in this building to support future services or enhanced services, that's just something we'll have to put into this cash flow and determine our ability to do that.
If I understood you correctly, there are some things on the horizon we think we're gonna have to purchase.
No, there are some capital projects we're looking at. The main one is that we're looking at moving, actually my department, upstairs. We're building out the, what Sean refers to as the boneyard. And, then look at utilizing this space here for clinical revenue generating services. And I think that was it. I think that's, one last piece. Oh gosh. Right here, interim funding equity contribution. We had a requirement to fund $2.2 million for the certificates of participation. To pay the interest on, that portion of our interim financing for the project. We're gonna jump to $115,491 per month in March, and then have that for 6 months. And in August, we'll met our full requirement for the funding. So we either have $115,000 of cash flow that we're no longer mandated to utilize for a specific purpose, or we just have flexibility. We can use it for capital projects, we can use it for new debt, if we have to do some kind of financing for something we want to do, we can use that for the debt service on that, or we can just keep, since it works for our cash flow, we can keep putting that into our bank account and start setting up our debt service reserve on the permanent financing. So that's great, because that's almost a year. Well, it is a year. Our first payment is in September of 27. So now we're looking at potentially having $1 million sitting in there, which would be make me really happy. So that's it. Lots going on now. Like I said, lots going on, and the high majority of it is positive.
Oh, yeah, so that operating income loss at the top, the third one down, that's the gap we're trying to close. That's the gap with swing and some of the other things that we really want to close down. And that goes right into the bottom line. Right into the cash reserve. So.
You can see in June, it's down to what, 159?
Yeah.
Yeah.
It's based upon the volume that we, historical volume that, and that we think that we should be able to capture now that we just got another provider. So,
And MRI.
And MRI, well, in podiatry,
yeah.
and I think swing is gonna really start closing that gap. If we can really get that moving, that should be able to
And
close.
we've got the positive variance in our interest income too.
Yep.
Yeah.
Almost $300,000.
Have we prioritized what we're recruiting for, podiatry, cardiology? Is there a priority list for it?
There is, so we've at this big whiteboard up there that has all the referral percentages, so we can see how many we send out, and so we prioritize by that. But then sometimes like we may have that, but as PDH was also recruiting, and then all of a sudden recruits, so sometimes it's just what's available and what kind of knocks on your door. So, but we do have kind of like
But if you weren't competing with someone else, what would it be at the top of the list?
Well, we actually, when Brady and I met with the other critical access hospital CEOs recently, everyone kind of put all of their druthers in a hat, and we had all the same similarities, and so we're finding that if we can create these partnerships.
Yeah.
Where we may not have quite enough for them to stay busy in clinic, but they can go to PDH or mayors or what have you. That's really, I think that's the key to our success and
Yeah.
recruitment, that we can bring them in, and maybe eventually they'll get so busy and they love Seneca so much that they become ours, I don't know, but, you know.
Of course, that's.
But
what happened.
we can position really well with our new building, we can position really well for any kind of surgical interventions because we'll have the most up-to-date OR as well. So, you know, you think of way back when, and I don't wanna go back too far because we wanna move this along, but there was this whole push for the 5 hospitals in the Northeast to work under some sort of a structure. Remember that? Structure with another CEO over all of us, right? And we all kind of rejected that, but what we have done, and I think it's been very telling about the environment for critical access hospitals and rural healthcare, is you join hands or you die. And I think, I mean, it's just, I hate to say it that way, it sounds so macabre, but you cannot survive if you're standing on an island by yourself anymore, you can't. And I think that every CEO is starting to look at how do we bring, like the podiatrist, how do we share this podiatry service line where we can all have access to it, but none of us alone can do it.
Right.
And I really want to applaud, you know, all the CEOs for thinking that way and getting out of their own way and not being so territorial, right? The world's changed, you can't be that way to survive.
Yeah.
Because I think PDH has a cardiologist. They have some
Hard
cardiologists
time.
that come up.
Yeah.
From, I think from Tyler Force, right?
Yeah.
Or some.
So
Davis too.
in,
Moderation versus competition.
yeah, in my, in the referral report that I put in on a quarterly basis, you'll see the numbers. There's like general surgery, orthopedics, nutrition. You know, so that it's like 12.4, 12.9% of our, the referral base. And then it drops down to about 6.9 for other services and so on. But you'll see that when we bring that report back at the top, and that's what I put on the board. You know, but recruiting, I mean, there's a little bit of artwork to it. So sometimes you want this and something out of left field comes that. So sometimes the opportunity knocks and you have to move quickly on it.
Yeah, makes perfect sense.
Yeah, and I do say that, and I have no data to support this whatsoever. So just anecdotally thinking, as I see the environment, I think that specialists are so inundated down in the valleys. They're so inundated that I think they're looking for something a little different. And if they can go from one place to another place and they get that variety, and they're seeing the real service of the population, I think there's a little something to that. Where fry or burnout is real down there. And I think that if they can have another alternative, they would seek it out. So that's just my thought. No data to support that. 44 years of what's going on. All right, sorry, Steve.
Get services down in the valley.
Oh, it takes forever.
Wow.
Yeah.
Yeah, sorry, I took us off track.
Well,
No, that's okay.
That was our battle down there, and it's just like, no matter how many providers we brought on, we had, to the river go out.
Yeah.
Impacted everything, right? Or we thought we had capacity, something occurred. Calusa went out of business, you know, and then the capacity was gone. Orville, it's just like, it's a constant.
They're still open though, right? Or
They're still open, but in,
They're running
on
services.
February 14th or something, there's a date out there that they're gonna go out to auction.
Yeah,
Is what,
Really?
yeah, however that works.
that's really interesting.
wow.
I'm very glad we're all here. That's-
Keep your paddle down.
All right. Are we good with the cash flow, Steve?
Yeah, yes, thank you
Thank
for
you.
that, that's what.
All right, so then I guess we're on to our.
Let's skip that one, save those for last. Real fast on the interim financing summary, the only thing I wanna point out is, even if you could just, go down to page 2 or 3. Yeah, So, and so it is kind of good. And so we've talked about this before, but because of the delays that we've experienced and in paying out our pay applications due to various reasons, our loan draws structured, so the money was coming in regardless, and then we did get behind due to some administrative things that we had to settle with the USDA. And as far as that goes, I think the fact, although they're supportive of the project and want to see it move forward, I think the fact that they let us send our request during the government shutdown directly to Western Alliance Bank for payment, with just Western Alliance doing that initial review, we had to say, yeah, if the USDA on the subsequent review finds something, we may have to bear the cost of that, but that's certainly not the case. That we developed a good trust with the USDA, and we got into a rhythm there, and the shutdown actually proved to be a positive thing for us, and bearing the fruit of that now. But because for that period in the middle of 2025 where we had to hold pay application, we developed balances within the trust accounts that the loan draws go into, and we've been earning interest on it. And we're now, Jerry mentioned that in the current fiscal year, we're at 297,000 positive the budget, which is almost all from the two funds. We have almost $468,000 of interest earned between the two funds. And we'll just have to see how that works out, but it just never hurts to have those funds. So at some point, we'll have a discussion with the USDA about what we can or can't do with that. On and on and on. I'd love to just throw.
Are there restrictions on that interest? Any?
I haven't seen a thing. I mean, I don't know. I mean, I don't know, the short answer. Anyway, we're more to come. So, Ethan, if you want to go, if any questions on that, and the rest of the stuff is just the standards stuff, is us funding the monthly interest payment and the payments that we did make. We did not make a pay request in December, sorry, and we did pay request 18 in the first part of the new year in January here. And we have pay request 19, which is for the pay application for December, sitting with Western Alliance Bank right now, and USDA has said go ahead and continue that process of going to Western Alliance Bank, so that's great. Any questions or?
Yeah, you go to the top again, just want to see them. Okay. Okay, great, thanks. Good.
And I'll just go to revenue cycle. And the big thing I want to talk about here is, yeah, let's just stop there for a minute. So when we met last, in the first early part of the month, and we looked at November's information, there was some discussion. Shelley brought up that, what's going on with the AR days, insurance AR days greater than 90. And we talked about that in some regards, the month of November was some algebraic anomaly kind of thing. And I said, if we develop a trend and doesn't reverse itself, then we need to talk about it. And that's exactly what happened, is that it continued to grow. And so we had R1 go in and do an analysis of it. And there's a couple things that are going on there that is going to demand attention, for lack of better words. So, yeah, if you go back, no, just say, Ethan, I'm talking about, that you go back to September, so our over 90 days was crazy. 20 and then 19, our client assist, the client assist started to grow there. First Medicare Meridian, our Medicare administrative contractor, or MAC, they started, there's a thing called assignment of benefits, and it's where a provider fills out a form, it's filed with Medicare, and the provider says, I'm assigning all of my pro fee dollars to a particular whoever, in this case us. And that means that we pay the provider for their services that they provide, and then in turn, we get the professional fee payment as part of that. And so Medicare thought that these forms had not been properly completed, and so instead of like going through and seeing who was or wasn't, they just stopped paying all claims with a pro fee on it. And it was the whole claim too, so I think it stirred up everybody, and now we're starting to see some not the right word is actions by other payers about who's credentialed and what's this relationship. A lot of what happens is that we have patients including myself, I go see a specialist in Reno, and my doctor wants labs. And so he writes a lab order and I take it in and we get the lab work done. Well, that doctor's not credentialed with us and shouldn't be. And so now we're starting to see where payers are looking at that, so it's not credentialed with the hospital. Now, who needs to be credentialed with the hospital is like our radiologist group that does the readings and all that. So it's turned into a bit of a to-do. And so we're seeing the impact of it in two places. We're seeing it on this December column, we're seeing it in the over 90 days for insurance, where it's gone to 27. In this client assist, we're starting to see where R1 is sending us back claims saying, hey, we're getting denials from the payer or we're getting claims returned, or whatever you want to call them. And so what R1 is doing is what they call it, it's called a work item. And they'll say, we need Senate to look at this. And so it's been put in client assist under a work item. In addition to that, within our client assist, we're getting other items not related to this particular occurrence or environment, where R1 is sending stuff back to us. So transparent, we're falling behind on our work items. And so what we talked to with R1 today is they're gonna do three things. Is that they're gonna look into this issue about the credentialing and pro fees and make sure that there's nothing there, that if we truly have a physician that should be credentialed, we're gonna have to address it. If not, we're gonna fight it, or they're gonna fight it. Second thing is they're gonna go through our work item. They're gonna go through the client assist. What they wanna do is they wanna make sure that there's not something that's been assigned to us that should be R1. It happens. It gets assigned, or who it's been assigned to. Has it been assigned to the right person? If it sits in a general bucket, nobody looks at that general bucket, or whatever it might be. So it's one of the things that we've talked about previously that, we're enthusiastic because we thought that we were really starting to do, being able to do revenue cycle management and not system management and other things like that. And we've been through the mill on various things. There's a whole list of things, and we have to get back to revenue cycle management. And I think what we're gonna do is, we've talked about this again today, is that I think we're gonna bring R1 either here on site or have them through video. I think on site it would be better. Whether we wait for the golf tournament or whatever, R1's a nice sponsor, is that we bring R1 in so that they can present their findings. And so it's not like Steve saying, it's Sarah Lynn
We
saying.
can have more dialogue too.
Yeah, and this is what we're seeing, we're
Yeah.
working your claims and here's what we're seeing. Plus it's challenging for us to bring things forward because that's a bit of a new environment is for us to provide, if you want to use the word critical feedback on things and then do it. Because the other thing is that, you know, we're thin in this facility. And so now you're gonna potentially put additional workloads on people that are
Yeah.
already maxed. So it's just something, there's no good answer, but
There must not have been a clear reason code, that was obvious, as to, for them denying, not paying us for the pro fees.
yeah, it's
The
there.
whole claim was denied and it was not clear.
It must have been a reason code that included the word credentialing, because, Ethan, if you could go to, and I don't know why they didn't explain it better why they didn't explain, slide 15, why they didn't explain it better in the, explanation. Is there a slide after this? No, there isn't. Okay. Because if you can see here, credentialing is $332,000. So R1's gonna go into this client assist, make sure that the things that have been assigned, now it says R1 credentialing, I don't know what they're gonna do about our credentialing. The other thing is Brady has offered out some assistance on the credentialing side, through his connections with Enlo. R1's gonna look at the same thing, if they can see something there where they can help us with this, that'll be just the big focus. Them to tell us what's happening. Good news is it's right there.
So Steve, this must be happening to
Yes.
any facility where someone goes, where they have a position over here, writes their script or whatever it is, and they go over here, so it has to be happening all over the place.
Yeah, that R1 actually, is engaged to do a similar thing that they're doing for us for the hospital and Alturas Motor Medical Center.
Yeah.
And we were talking about that they're experiencing the same thing up there. So.
That's good to know.
Yeah, it is. So this will be like our guiding light or whatever. It'll be our measure because this is what we want to see move. Yeah, return mail is in there because, again, we can't right now. We send return mail to a collection agency because they can do what's called a skip trace function and look for it. They're probably not going to get anything out of it. We did send, right before the holidays, we sent a complete kind of state of the state to Cerner Oracle about our issues with, specifically with patient accounting, our relationship with the AMS, the customer support with Cerner Oracle, and the identifications of portions of the system that were never built properly or at all, and have requested them to address all of this. What they have offered up, which is great, that Brady had brought this up at one time, about assessing the system, and they do have a team that'll come in and will assess how we use the system, because they can see it and they can see what's not working, what's we're not using, what's broken, whatever, and we'll take it from there. So.
Do we have a time frame for that?
That would be enlightening.
We're going to have that initial meeting with them here in February. And then once they have looked at it and done that, then they'll provide us with what they think they can do, how long it's gonna go, or is some of this gonna cost us, I don't know.
Do they have to come out here for this?
They haven't said that yet. Because they can just sit there and look at our system, Kansas City or Nashville or everywhere. I think it's a I think it's a US based function of Cerner Oracle. It's not an offshore, which is helpful. Because that's been a big part of our challenge is working with the offshore, mainly it's the AMS, customer support, so. So that's it. We did see, I got received a mid-month report for January. We did see the numbers come down. I don't know if there's a rhyme or reason for that, but they did. So a little bit. I think that you solved. So,
Yeah. Well, thank you for looking into that.
not at all, because it was certainly worth the look.
Yeah.
On the good news is, Ethan, if you can go back real quickly. I want to do two things. So next page. Real slow. Okay, so our discharge not final bill, you can see in September it was 19.5 from 20, it's gone to 14.4 to 12. The report they gave us today was 10. So we saw claims going out, but the payer's not happy with it. So it's better than it's sitting here, at least we know. So that was why I was getting a little bit enthusiastic because when we were at 20 days in October, we were all just good to be tight. Big part of it was the radiology thing we worked with, and then we went into a problem with the Cerner talking to our billing clearinghouse. But now we appear to have those fixed, and now we get to jump on to this next adventure. So.
Thank you, Steve. Any other questions for Steve?
Thanks, Steve.
Thank you very much, Steve.
Thank you.
The time.
And just for 1 quick second, thank you, Deborah, for the order, item number 6. You were not in attendance, so technically you are abstaining from voting.
Thank you.
Yes, thank you. Okay, so let's move us on down to item number 9, new critical access hospital and skilled nursing facility, contingency usage request 012. Donna, are you on?
I am. Can you hear me?
Yeah, we can hear you. Go ahead.
Alrighty. So, this is contingency usage request number 12. We have a mix of requests for construction contingency, owner's contingency from both a plus and a minus on both of those actually, perspective. So, just kind of walking through these, the foundation waterproofing one. So the first two are requested ads from Molly Hamlin, and the explanations are down below. Foundation waterproofing was some additional information was required for a complete design around this scope within the construction project. And so it was frankly not very clear in the initial drawings. And when it was made clear, there was an ad of the 53,000 and change for item number 44. Item number 45 was when we similar to we had previous requests or previous contingency usages for increments 1 and 2, reconciling the bid documents to what got approved through HCI. This is a larger one than Inc. 1 and 2 was, just because there were so many more moving parts that got clarified, updated, expanded upon. So that's what item 45 is. Last meeting on the 8th of this month, I had on contingency usage request 11, we had asked for the mock-up in order to get the capital engineering's change order process. We asked for both the retest number 2 or the retest, which was test number 2, and test number 3. to be taken from owner's contingency. And since then, I've been able to have the conversation with the general contractor, um, indicating that that third test needs to come from them, not from owner's contingency. So items 46 and 47 are reconciling getting those dollars put back into owner's contingency and frankly back into construction contingency too, because will be a deduct from the general contractor's contract. The item number 48 is a separate agenda item as far as the contract itself. But in order to execute the contract, we need to get the board's approval to supplement the budget line item by the amount that you see here, the 112,154. The budget line item had 98,000 in it, and the with the proposal and the vetted total scope that's needed, we need to supplement that line item by the 112 in order to get to the total indicated in the footnote of 210,154. And then the last line item, also a new contract that's under a separate agenda item that does not have a budget line item at this point in time. So we need to get the full amount approved for from owner's contingency for that 116,905. And then lastly, you'll recall there were contingency usage requests in the past that we thought that absent the grant, so put that aside. Previous requests were we thought we needed to supplement the lab, supplement the equipment usage. I'm sorry. We needed to supplement the equipment budget line item in order to accommodate the net new lab equipment in the new facility. And then we realized that when we got our updated budget from Entroba, we didn't need that extra. And so we had asked for the contingency before to make the lab net new. We had then realized we didn't need it. So we did a contingency usage request to put it back in contingency. And then we got the grant. And so additionally, we're indicating that we're putting that grant amount back in the contingency. So that's what this amount for the 398,000 is, the grant amount, and we're saying we're putting that amount back in the owner's contingency. We did talk with USDA about this yesterday, and I am working to get that all the details worked out of how that looks, and that will need to go to USD to make sure that we're all on the same page of how this gets put back in contingency. But we believe that this is correct, and I hope you will be patient with me if there's some changes that need to result if the way that we're representing this to USDA needs some tweaking. So that let me know if you have any questions on that or anything else within this contingency usage request.
So Donna, I have a question for you. 49, the medical gas inspection, were we only able to get one quote for that one?
We did only get one quote for that. It is a very specialized service, and we have the need for the best for this service. We've got we really need to, so this entity that we that we'll review in another line item or another agenda item is who Seneca has worked with previously. I've worked with them at other projects, and they really are the experts in this field. And so I highly recommend that this is the way we go.
But we went out to bid for it though, and we only got one response.
We did not go out to bid.
It's professional services
Professional
only.
services,
Yeah,
okay.
no need.
Do you wanna say something?
Don, nothing on this particular list, but while I have you available to ask this question.
Uh-huh.
As we look at these contingency requests, some of them, I almost feel like, why weren't they included in the original bid and planning? Cause some of them are so basic to constructing, like waterproofing a foundation, you know, and I feel like, kind of a question that if I were just a member of the public, I would say is, well, why didn't you guys think of that in the original bid package? And knowing that not this contractor, not saying that, but some contractors will leave things out like that in their original bid, and then through the course of the project, they keep coming in requesting contingencies because they just discovered this or that or the other thing, and it helps them be the lower bidder. So I kind of, thinking about this the other day, thought some of these are no-brainers, we need to do it. But some of them, you know, you almost want to say, why wasn't this discovered in the original building proposal bid process?
Yeah, no, it's a very good question. For using the foundation waterproofing as a specific example that we can expand to others if we want to dive into some other ones as well. But the foundation waterproofing, it was the way that it was depicted on the bid documents was not as detailed as it needed to be. And so what the contractor, you know, we do push back. We have weekly meetings with the architect, the contractor, and myself, full open conversation of who's responsible for what we're willing to consider, what we're not willing to consider. We being the architect and myself, as far as what the contractor is bringing forward. For this one, for example, they initially said that they didn't have any money in the bid for this, but there was a note on the there was some indication of this need on the drawings. It just wasn't detailed. And so after negotiations in those weekly meetings, what we came to is you have to deduct a reasonable assumption that you could have had to properly waterproof the foundation. So now that you have all the details that are required in order to properly waterproof the foundation, tell us what the costs are for that. And then you have to deduct something reasonable that you would have assumed within the bid. So we have those conversations weekly, going to trying to be, our goal always being firm but fair. And just knowing that the drawings are never perfect, and we're just trying to again always be firm but fair with the contractor, and bring a reasonable expectation for any added costs to the board.
Thank you for that explanation, because it makes me feel a little more confident to know that you have been pushing back and negotiating.
Oh, absolutely.
That type of thing. So thank you for that.
Yeah, definitely.
Any other questions for Donna on this? No?
Question from Sherry. Good question here.
Yeah.
Yeah, that was a very good question. Thank you, Sherry. And thank you for your answer on that, Donna, because that was very, very helpful.
Good. Glad to hear that.
All right, so that being said, not hearing any other questions, do I have a motion to approve contingency usage request 012?
I move for approval of the use of contingency usage request 012.
Got a second?
I'll second.
Thank you. All in favor? Sherry? Sorry.
Shelley?
I'm combining both.
Looking
your
at
names.
me, Shelley? Aye.
Shelley, Sherry.
Aye.
Ken,
Bob?
Rich,
Aye.
and I'll vote aye. Thank you. Okay, so that moves us on to item number 10, which there's a copyright there in the middle, if anybody needs it, I'm just throwing it in my hand, look at it. That's not happening. So this is the new critical access hospital skilled nursing facility transition and activation planning contract.
So, oh, I'm sorry.
Sorry, I was gonna say, requesting the board consideration and approval for value of $210,154 to Yellow Brick Consulting. Go ahead, Donna.
Okay. So this service was put out to RFQ, request for qualifications and proposals. And we did receive two bids or two proposals back. Brady and Judy were pivotal as always with their review of the two proposals received. We ultimately had a meeting with both of them and were able to vet the services that they were both proposing on as compared to the request for proposal. And it is our recommendation to go to contract with Yellow Brick for their base fee plus the dress rehearsal ad service that's in their proposal. So if you're scrolling down, you can look at their base fee on page 30. Thank you. Of 127. And then the decided upon additional service that was agreed to be needed is the dress rehearsal that is
Yeah, so that was my question, Donna. So I think what we're being asked to approve is the base fee plus the dress rehearsal, not the rest of the optional items in there, correct?
that is correct. And dress rehearsals on page 23. So the sum of that 127 and change plus the 83 for the dress rehearsal scope is what is being requested for approval by the board. And all the other services within that proposal are itemized with a fee for the scope. And we have confirmed with the consultant that if we get farther into it and we see a need to add one or more of these other services, that of course we would bring back to the board for approval for requested approval, that those fees would be honored as we get farther into it. So we have it all itemized. Right at this moment, we feel that the scope that is needed is the base fee plus the dress rehearsal, and everything else is there if needed.
So Donna, is that the 112,000, 154?
No. So the 210 yeah, minus the 98. So the 112 is the 210 minus the 98.
Now, the patient transfer coordination, we didn't need that for our skilled residents.
I don't think so. I mean, what we're assuming is that we will definitely have 16 residents that will require movement, which is not a lot in the grand scheme of what Brady and I have experience with our current census on inpatient.
Yeah, I figured that
Not a
probably
lot
wouldn't be
because
necessary for
be
that.
going on there unless our swing bid program always. So I think we can handle it. You know, we will have to coordinate with our local EMS services for ambulance transports and things like that, but with 16 people, I really do think it's doable with extra sets of accounts. You know, because we're basically It's almost net new, all beds over there. So we're not even moving their beds, we're moving them.
Right.
Yes, and many of them can be transferred in wheelchairs, et cetera.
I see this a lot with moving ICU patients, post-surgical patients. You see a lot of this help, you know, because you got to coordinate all EMS and all the pumps and everything. So I think it's fairly straightforward.
Yeah, with our transition process that we used for years. Like these services that we're asking the board to review and approve are the bare minimum of such services because of what we've done. And so we'll do all of our transition processes before, then we'll plug it into this group. But when it comes to, the big thing is when it comes to CDPH and, you know, all of those agencies that you're interacting with, you want belts and suspenders with doing that, making sure you're hitting each one so that when Jenny gets the hospital delivered and passing the keys, we can actually open the door, you know? So that's kind of where we're thinking is our experience can help, and with our team, that really gets them excited and engaged and, you know, how they're gonna work in their area.
Because what CDPH really is going to be focused on is the what ifs.
Yeah.
Well, what if this happens? What are you gonna do? Where's your crash? Where is this? You know, how are you going to page this? Are all of those what if things that need to be practiced, and each staff needs to be able to speak very articulately to those processes, and that our policies are up to date to reflect all of that. I don't think with our small census that the efficient movement will be an issue for us. I mean, we can even use our own wheelchair vans as well. So,
Thank you, I appreciate that. The other question that I had, that's, okay, guys, I can see this group has quite a lot of experience with really large facilities. And I was wondering how that would translate over to us being so much smaller and being critical access. And whether we think that's an issue at all.
No, we've asked that question. The specific person, the head project management for the team. They do have, and they have just done recently some critical access hospitals. There's both companies, when we have them, we ask them about critical access hospitals and all of that, because it's a smaller, it's just scale, but it's smaller in that sense, and there's a little nuances of each type of facility, yeah. The company that is presented answered the questions better and had more examples and experience. That's why all of us that reviewed them felt better with this company. This company was also the lower bidder of the two. And they were more detailed, polished in their analytics, like in the back, because this is something we're going to present here, so you guys can send its timeline. It's heavy project management, which is really good.
Important for this kind of thing.
Yeah.
Yeah, the other one was talking about, you know, ICU, elevators.
Things that we don't have.
Things like that. It's like, oh, my favorite
Yeah, okay, thank you. Any other questions on this, board members? No? Somebody want to make a motion to approve the contract? Well, approve
I'll make
the
this.
maximum value of $210,154, which is the base fee plus the dress rehearsal.
And just directly to execute.
Yes.
Yeah, thanks.
Can you second it? Thank you. All in favor, Rich?
Aye.
Ken?
Aye.
Sherry? Aye. Shelley?
Aye.
And I vote aye.
Thank you, board.
Thank you, Don. And thank you all for doing such a thoughtful job vetting this out too. Okay, that brings us to item number 11, new critical access hospital skilled nursing facility medical gas inspection certification contract.
Yes, so that,
$16,905 to Thurston's yearly analysis. Go ahead, Donna, sorry.
I'm sorry. Yeah, so this is the proposal that we were referencing when we were reviewing the contingency usage request memo. And the this is based on both the testing requirements as designated by HCI as well as the schedule provided by the contractor. The executive and the person that works in the field that developed this 116,000 based on those two sources feels that this is conservative. He's making sure he's covering the facility to give all the service that's required given the expertise level of the installers. And potentially could be in excess of what is needed, but he wanted to make sure that he's covering us and not having to come back for a change order. So he's asking for a contract in the value of $116,905.
And can you explain a little bit more about how this works? Because this is all news, I don't know anything about any of this. So I see it goes over 12 weeks, I think it said.
Goes over what?
Is it a 12-week period? I can't remember how many weeks.
No, it's for the duration of the project. It's just there's a little bit at the beginning, and then they have to come before at each so there's the different areas that the contractors divided. Actually, the architects have divided, and the contractors are following as far as the schedule of their construction. Like the acute care is area 2. Then they're moving on to the ED and so all those different areas. So they're going to be similarly trying to close up the walls with the by installing the drywall. And before they can do that, at each time they want to close up the walls, the med gas inspector has to come out and do the testing. So it's the multiple trips out is what this includes for each different area as defined on the contractor's schedule. And then the final testing, both before the booms are put in the OR and endo, as well as he has to come back again after the booms are installed in OR and endo. So it's those touch points, if you will, that this proposal covers. Does that answer your question?
So much more sense, because I thought, are we testing in the period leading up to opening? Or are we testing for when we pass? So that makes a lot more sense to me.
Okay, good.
When do we expect this would start approximately?
His next or his first coming out to close when they're closing up the walls. I don't have that on the tip of my brain. I'm sorry.
Talk to Jimmy, and they're going to start putting drywall up within a couple of months.
I'm just curious.
Yeah.
It's okay, Donna.
Thank you.
Okay. All right. Any other questions on this item? No? Do I have a motion to approve the medical gas inspection and certification contract?
I motion to approve.
Thank you. Do I have a second? Second. Thank you. All in favor, Shelley?
Aye.
Sherry? Aye. Ken?
Aye.
Rich?
Aye.
And I will vote aye.
Thank you,
Thanks,
board.
Donna.
Appreciate it.
Thank you.
We're still with you though, so for the update.
All righty. So I'll let that document get pulled up, and then I'll dive in. Number 12 there. The next one. There you go. Thank you. Thank you, Ethan. Alrighty, so starting with schedule, we've been talking about this for quite some time now. I am bringing to the board the update of bringing this to a point of resolution, if you will, in that, we've been talking about it for a while, and the change order for the requested 105 calendar days to be added to the contractor's schedule has been signed by the architect, the contractor, and Seneca, and sent to USDA. And so so it's pending concurrence by USDA, but it's a step in the right direction that we have all those entities having signed the document to go to USDA. And I wanted to give the board the update on the implications to the dates, resulting dates. So in the report, you see on the right-hand side there that what that 105-day ad results in is having a contractually required certificate of occupancy on July 8th of 2027, and a final completion of 8/23/27. The things that happen in between those two is an overlap with Staff and Stock. So Staff and Stock can be going on as well as the contractor can be in there fixing punch list items such as paint touch up, or I don't know, installing something that wasn't that was part of their contract but wasn't part of what was required for certificate of occupancy, or things like that happen between certificate of occupancy and final completion. So those are those dates. Currently, the GC is ahead of that schedule and has a goal and a vested interest to beat those dates. So it's good that both we want that and they want that. And their target certificate of occupancy right now is April 14th of 2027. We are tracking deliveries of medical equipment, furniture, teeing up Staff and Stock and licensing. All of that is right now pivoting on that 4/14 date to make sure that we're ready if assuming that they're able to make that date. What that results in is with an anticipated 2-month time period for Staff and Stock is first patient on 6/14/2027. So that's our goal, our amended goal from what had been the base contract with the general contractor. The target certificate of occupancy, I want to make sure that the board is fully aware, is not contractually required, in case that wasn't clear. And the contractors the whole team is working diligently to do what needs to be done to meet that 4/14 date. But there is potential for slippage, and we're team working diligently to remove those constraints. Again, the contractor has a vested interest to meet the date as well. But there's no recourse because of the contract change if they weren't to meet that 4/14 date. Does that make sense?
Yeah, and if something just popped into my head though, EMS, we're gonna have to make sure they know when we move. Is that part of the transition?
Yeah.
Okay,
Yeah.
okay. Okay,
Or
thank
the
you.
TSC.
I
Yeah.
just, I had like, what if somebody shows up at the.
Not only helicopters.
Yes, okay, good.
Part of the whole plan, yeah.
Sorry, Donna, go ahead.
Yeah, no, I think that's a good time to break, just to make sure everyone understands, see if anyone has any questions, since it is a change to a key component of the project being the schedule.
Questions, board members? No. We're good, Donna, thank you.
Okay, great.
Yeah.
All righty. Contingency usage requests. I just gave an update on the previous contingency usage request. bottom line is, we've got approval for the Monley Hamlin changes through change order 3. Through change order 3, the more recent contingency usage requests are still with USDA for Monley Hamlin. For the soft costs, in summary, there was a series of them that were approved. And then now the later contingency usage requests are with USDA, waiting approval for those so that we can get those incorporated in the documentation that we send to USDA monthly. So some outstanding, some through USDA, and I think that we're very close to getting these all put behind us, to where this is just referencing the most recent, not going back to referencing 1 through whatever. Alrighty, moving on. No real updates on permit. Medical equipment planning, if we scroll to the last page, similar to last meeting, I'm providing this summary of the equipment purchases. The only thing that was purchased within this last month, or after the last meeting on January 8th, is item called within the instruments instruments category, for the that'll be moved over to the new facility. It's for the podiatrist, correct, Brady?
Yeah, correct.
Okay. So that's the only thing that was purchased. This will be a bigger number for sure in February, where there's procurement happening this month that is more significant. So just a heads up on that. But of course, it will will maintain this documentation as well as, of course, the budget.
Okay, thank you. Karen.
Yeah.
Go ahead.
Oh, okay. Then a summary of construction is there. Dry-in is mostly obtained with permanent construction, and where there's not permanent construction, measures have been taken to allow for interior work to continue. Wall framing and rough-in of electrical, HVAC, and plumbing is ongoing. Nothing new on support services. That's similar to previously reported. The submittal was made to Plumas County, and we're waiting for that for that review. And then the under USDA financing, we did make progress with referencing those soft costs that I was speaking of when we were above for the contingency usage requests. We have HGA and Building RX contracts, and following this report, those have been signed, as well as Wiedner's, and sent to USDA. So everything soft costs is in USDA's court for review, such that in hopes that we can put OR 15 is the one that is most affected by, or first affected by, those contracts. And once they can get all those cleared, they can provide concurrence with OR 15, and then continue that through on 16, 17, and 18. 19 has been submitted for payment. That's the one that Steve referenced. That's from December's work. And it is USDA has indicated that is being processed, where Western Alliance Bank approves it for payment, and USDA will follow, similar to what was the process that was happening during the government shutdown. And they have indicated that we should expect to be caught up by the time they're ready to review outlay request 20. So that one will go back to where USDA reviews it, and then it goes to Western Alliance for payment. Alrighty. Nothing to report on the other funding, and the licensing, staff and stock is what we reviewed in a separate agenda item with the transition and activation planning contract. And once we get that executed, that too will go to USDA and we'll be able to then move forward with getting that licensing support worked into the transition steering committees that Brady and Judy had referenced earlier.
Great. Thank you, Donna. Any questions for Donna on any of these things? No, Ken, did you want to say anything about the walkthrough?
It was great. It was just, it's, I don't know, it's kind of overwhelming when you go in there. You see all this activity going on. It's just everywhere. It's not just one corner of the building. It's going everywhere. I was impressed. It makes you feel good when you go through there.
It's pretty amazing, huh?
Yeah.
Yeah. Great, thank you. Okay,
Thank
so
you.
with that, I think that moves us on to item number 13, policies and procedures.
Hey, Donna.
Thanks, Donna.
Oh, you're welcome.
Board members, any questions, comments on policies and procedures? Any motion to approve?
I motion to approve.
Thank you.
Second.
Thank you. All in favor? Shelley?
Aye.
Sherry?
Aye.
Ken?
Aye.
Rich?
Aye.
I will vote aye. So now that brings us to item number 14, medical staff report. Question board approval. Dr. Ware, chief of staff, submitted medical staff appointments as approved at the January 13th medical exec staff meeting. Any questions, comments, motion to approve?
Motion to approve.
Thank you. Got a second?
Second.
Thank you. All in favor, Rich?
Aye.
Ken?
Hey,
Kelly?
Aye.
Sorry?
Aye.
And I will vote aye. And that moves us into closed session. We have Office of Legal Counsel, Government Code 54956.9, Office of Legal Counsel. Trade Secrets, Health and Safety Code 32106, reports involving trade secrets. Litigation, pending existing litigation, Office of Legal Counsel, existing litigation pursuant to Government Code 54956.9 D1. Public employee appointment, closed session due to Government Code, Section 54957, public employee appointment. And labor negotiations pursuant to Government Code Section 54957.6, Office of Legal Negotiators. And now we're in closed session. There we go. All right, we are back in open session. There were no reportable actions taken during closed session. That brings us to item number 17. Proposed changes to salary and or fringe benefits of the chief executive officer. Board discussion and possible approval of changes, consideration of awarding a performance bonus of $16,000 in total. Do I have a motion?
I'll move.
Thank you. Got a second?
Second.
Thank you. All in favor, Ken?
Aye.
Sherry?
Aye.
Shelley?
Aye.
And I'll vote aye. Rich had to drop 2 minutes before we can be back to open session.
Okay, so you want me to put that in the minutes?
Yes, please. Thank you.
At what time? I'm sorry.
2 minutes ago, so
Okay,
I can't read my watch.
so it was before we signed it, so 5:29.
Yes, thank you.
Okay.
Okay, so that brings us to our board committee assignments. A little of this with Rich dropped, maybe we should.
Well, take them
Sign all of
Rich
it.
is on.
on that one and this one. The
Yeah.
one that's gonna be really, really important is number one.
Is that all right?
That's gonna be huge.
Yeah, I know,
Yeah, I vote.
Well, you wanted to talk to him first.
well, are we gonna be having strategic planning discussions between now and our next meeting though, probably, right?
SPC?
Yeah.
Probably.
Like the formal public committee meetings?
No.
Not yet.
No, this is still gonna be internal
Yeah.
before we take it on the streets. Yeah.
So I think we can go ahead and move this item then to our February meeting, if you guys are okay with that. I just wanna make sure, as I didn't talk to Rich at all about the assignments ahead of time, so I didn't have to drop, so. All right, so then we'll change that. We're gonna table that item, Deborah. Thank you. And so that brings us to item number 19, board executive staff and department head required training. So we've already had to do the ethics training, right? The member of local agency, legislative body, et cetera, along with our department heads. If the board so chooses, we can have any additional employees do the ethics training. I don't know how far our levels go now. Are you aware of that?
So
Did just our department heads? Anyone?
no, we had this conversation with Noel a couple of years ago, was it, about about ethics training has to go deeper than just signatory. It's anyone that has influence.
Or decision making, right?
Yeah, and it went, whew. It's on the Form 600. I can talk to Noel about how deep it has to go, but we wrote a policy for it
Okay,
to show who has to do it.
okay.
And we did it. We're in compliance,
So
until
let's,
now.
let's pull that policy forward. Because-
Deborah, can I put you in charge of that, please?
Yes, yes, you can.
Yeah, because, we may need to be updating it with this fiscal and financial training component, which is new. starting in
Correct.
January.
And do we have Brown Act training that's new too, and SB 511, 411 or whatever?
We're doing some research on that right now.
Yeah,
Cause I think it's a new law.
there are some new guidance related to Brown Act, but again, that's another thing I have with Noel that I haven't got back from her yet. So,
Okay,
But there's that virtual training.
there is.
Yeah,
And
yeah, on the changes,
there's
yeah.
no HIPAA training in
Yeah.
this, or,
Not for you, you don't have
For
access
us,
to
we have
PHI.
access to patient information, so we
Yeah.
don't need to have the training.
But there's all these new things coming down where you have to have all this training and the Brown Act's changed and.
Yeah, but this fiscal and financial training is a brand new thing. And it's for members of the legislative body. Any official who's appointed by the governing body who makes decisions or recommendations regarding financial administration, budgeting, or the use of public resources, which I would argue
Is the same as as the
is
same,
our ethics,
it'll,
most
I
likely.
think just to play it safe, I think we need to follow the same guideline.
Yeah, so let's take a look at that policy and see if we wanna update it to add this. Now, that being said, I don't know that there's resources yet for this fiscal and financial training for the formal official.
That'll be another online
Yeah,
thing.
I probably, but I don't think it's available yet.
As of Wednesday, cause I did check Wednesday, today's just Thursday, there was nothing that I could find that was updated.
Yeah,
However, it was mentioned that it is something that is going to be implemented.
thank you.
So is this something that, do we wanna join ACHD for the next year? Cause they're the ones that are gonna have all this. See, we have access to that with our members, but I don't get much more out of them other than some of these updates.
We'll talk about it again when we talk about the
Okay,
policy,
that's
I
fine.
think.
Yeah.
how
Yeah.
much is that?
It's expensive. They're all
Yeah,
expensive.
you can bring forward and if you come across any additional ones that are options for us to do by the time our next meeting, if there's anything.
Yeah.
Then we can pick up.
And I'll present it to you and we can decide what to add. Yeah.
Thank you.
Uh-huh.
And so,
to take all these trainings at Chico's State.
Well, if you can show that you've taken them,
Well, that's, they're
yeah.
related to instructor-student relationships and stuff like that.
so the fiscal and financial one has to be done before January 1st of 28. So. Unless you begin your service on or after January 1st of this year, then you have to do it within 6 months.
What
What
service?
does it mean begin service? Does that include
Yeah.
appointments to your position, or if it does, so regardless of the fact you've been here for 8 years, you still have to.
I don't know the answer to
we might need a Noel.
Uh-huh.
that. Yeah. All right, good question. So, and then after that, we have to do it every 2 years, just like the ethics one. So just reminding that we have the ethics that we have available. If anyone had trouble signing in, like I did, I just brought it to DBK. Anyway, the fiscal and financial, okay. And so then we also have our sexual harassment training that is required every 2 years as well. So that's
We
another.
have to do that?
Yes.
I think I think we have that module, don't we?
You know, I
Because-
reached out
I
to
was
Jen.
done with all these.
This one-
So
this
we
one's
may,
a new
we
one.
may have that module, we can just send you the link to the module through your
Oh.
email. I think we have a sexual harassment module, don't we?
We do, and
I don't think there's access to it.
I think, here's the deal, is Linda used to be responsible for that
Okay,
one. And
let's
now
look
I
into
think
that.
Shanna says it's through pay.com.
Which is
So
like-
they have to get back to me.
Yeah, so again, we have to find a source for
It'd be
it.
great if we have one source and just do them all at one time.
Right.
I totally agree. with
All
you.
9 hours.
We need a
Yeah.
list of what we need. We don't have contact information
Yeah.
at all.
No.
Good, I
Need
have,
a legend.
We have to be able
I know.
to recognize it if it's.
I
occurring.
got Title IX stuff.
And now you can't cheat.
No, you can't, you got.
I love ethics where it times you and you have to leave that module up on the screen
For so long.
so long. everybody goes, well, I just go get a cup of coffee. and
It's like the
go back
voter
there."
ID.
I know.
Oh my
Is that
gosh.
painful or what?
So, I guess more to be discussed on that topic, but
You got
I just
it.
wanted
We
to
have time,
make sure
though.
everyone's
We've
aware
got
of it, yeah. We can get it going, so. Future board meeting agenda topics. Board plan session still there. And all these trainings, I was thinking we might wanna document them in a board policy.
Yeah, I think that's a good. idea.
And we don't really have much for board policies,
So
so
that's gonna ask me.
when we, not much. I'm thinking that when we do the committee assignments, we're also gonna discuss if we want an ad hoc board policy committee. Okay,
Tell me a little bit more about that board policy meeting.
well, Sherry would probably be a better one to tell us about board policies, because we don't really have them.
So I think,
This
here's
is-
another, I'm sorry, here's another thing that Noel would be able to say, you need to these, every board should have these 10 policies,
Right.
right?
Mhm.
And she could probably give you a template to say, here's
Right.
10 policies that every board needs to have.
I mean, these basic,
That's it.
simple things like
Super
the
simple.
right to the public to participate
Yeah.
and.
Change the name to protect
Well,
this.
that'll be Brown Act training for sure, but policies like, resolutions and stuff like, there's certain policies, but
Yeah.
I'm sure Noel's got them right on the tip of her tongue.
That's what I was
Yeah,
gonna
I
say,
appreciate that.
or even the special districts association.
Oh, yeah, they'd have it too. That's why consideration for joining again. Yeah,
Okay. Any other topics that any board members or staff want to add that you think of now?
Thanks.
All right, then our next regular board meeting will be Thursday, February 26th at 2 p.m. here in the conference room. And meeting is adjourned.
great. Thank you. Hey, we just got a request for the, sorry. Stop sharing and then
Wait, yours is not sharing.
the red button, yeah, stop share.
We're still
And
recording now.
we're at.
There's a big X up at the top, huh?
Yeah.
Here on the Zoom, and down the right.
In,